review. Again, thank you for coming. This is the second half of the training, what I'm calling advanced, the first part being the basic, where the first part we just kind of introduced you what chaplains do in a routine visit. We talked about advanced directives, and we also talked about hospital protocol, those kind of things. For today, we want to kind of shift gears, kind of do a little bit of review of that, especially on the advanced directives, because some of the ministers kind of go, what do you keep talking about advanced directives? What did you get down to the nuts and bolts of what chaplains do? Well, that's what we do. We deal a lot with that basic thing of what patient rights, patient's choices, and medical availability. So we will be doing that a lot. You will see as you work as a chaplain. As a minister, you walked in and you worked with your family members and your people from your church, and you didn't deal with that a lot. They may have asked you questions, you go, well, I don't know, let's go ask the nurse. And I'm not asking you in this to become the professional, the one who knows all about advanced directive, but I want you to feel very comfortable with advanced directive. You will be able to answer a lot of their questions. But some things like in advanced directive, there are things that change, state laws change, situations change, where we never quite know it all because it is a huge topic. But I want you to feel comfortable in that area. And then today we will look into some other areas of how to deal with our patients in their ministry. But I see this part of chaplaincy ministry as a huge part of what is going on in the hospital. A lot of it's positive. My normal day, having been a hospital chaplain for 14 years, my normal day is positive. People get better, okay? Because people tell me when I introduce myself, hi, I'm a hospital chaplain. Oh no, I feel so sorry for you. It's like, no. Prayer works. You know, people get better. There are some huge successes. Most of my day is easy. And most of your day in taking care of patients is easy. But when you're kind of the on-call minister and on-call chaplain, you kind of go, well, every time I come in, it's bad. Well, yeah, it's kind of crisis time then. So you kind of get the perspective that's every day or every hour of the hospital. Not so, because there's a lot of great things that happen. But your ministry will tend to deal with the negative that you're going to turn into the positive just because you're there. Okay? So it may feel sometimes like, oh no, it's like the kind of ministry you do might be dealing with trauma, but in most cases, patients get better. So in reality, we all get sick. In reality, we're all going to meet our Maker someday. Well, what your ministry might be in some of these trauma crisis areas will be meeting those families in that moment. I look at that as really a holy moment, a time where we spend with family, a time where we spend with patients, a time where there may be death involved or deep, serious illness involved, some of them entering into eternity in that time. If you look at this ministry as a holy moment, as a moment that you could share with that patient and with that family, to me, it is a joy, if I could put that in quotation, a joy to be able to be there during that moment. Now, when you first get into it, you may think, this is not fun. So I'm not talking about fun. I'm talking about a pleasure and an honor to be there for that moment. Where many times when I come home, it is not that kind of, oh no, an awful, depressing day, but what God helped me do that day, okay? So if you look at that kind of perspective, it is not like, oh no, I am going to be a volunteer chaplain now working in those areas and my day is going to be full of misery and pain. Well, it can be full of pleasure of how you deal with those people and help them through their day. In these decisions, the first decision we kind of make is their advanced directive. What does the patient have? They may not have an advanced directive. They may have it documented very well. They may have just spoken the words to their wife or to their husband, don't ever let this happen to me. So according to what they've given us, we want to do and we want to follow the advanced directive. Then we want to know what is the diagnosis and prognosis, and I'll go into more definition of this later. We want to know what the patient wants, or what the surrogate speaking for the patient wants at that moment. And then we want to know where the physician is on this. Are they ready to let go? Do they have other medical plans? Do they have other treatment that they can use? Where are we at that moment of talking and coming together as a consensus of this patient's plan of care? So again, going back to the advance directive, some of these things we talked about before, and we're going to kind of go through because I want you to hear them again and again until you feel comfortable with that. The living will is needs 2 witnesses on that. In most states, it does not need to be notarized. I forget about yours. Does your state need to be notarized? No, it does not. Okay. There's all kind of different state laws. So if you get people in your hospital that are kind of live partly here, partly there, I would tell them to get advance directives in both different states, because they may be living here part of the year and there part of the year, and that way they can have one for both, or at least get to know the rules of both. The healthcare surrogate, and sometimes even that term is named different. Sometimes it's called power of attorney for healthcare. Sometimes it's called proxy. But it's a different kind of term, meaning the person is going to speak for you on this living will, on this advance directive. And then advance directives include the living will, the surrogate, and organ donation as part of those choices. Medical directives in advance of what? In advance of old age, in advance of some kind of cardiovascular trauma, in advance of even electrocution or drowning or car wreck. You go, Larry, that is morbid, but it is life. It is what happens to every person in this community someday. Some of us get the pleasure of dying on the golf course when we strike the hole-in-one and we get so excited, we fall over dead and we're too far away from the paramedics, and we don't really need an advance directive because they couldn't do CPR fast enough, and then when they tried it didn't work, and we go, well, why did I fill out that little silly piece of paper for? Well, most of us don't have that kind of data. It's usually, I get an illness, I go to the doctor, I go to the hospital, I try all these treatments, they try this, they try that, I'm on life support, and then somebody's got to choose when we take me off life support, okay? That's the normal real world. So most of us need advance directives and to make that decision of what's right for me and what's right for you. I hope when I get sick one day in the hospital, they're going to say, Larry, you're getting better, you're going home tomorrow, you're doing great. But other times in my life, there may be a time when they say to my wife, Sarah, we've done everything we can for Larry, and we've given him all these kind of treatments, but the prognosis is poor. He's not going to get better. We need to make a decision. When that day comes, there will be 4 different possible choices within a poor prognosis. Terminal, end stage, persistent vegetative state, or brain death. Now, my wife already thinks I have brain death. But beyond that, I mean, one of those choices for me in that critical day when I can't get better and the doctors be making that decision for me. And remember that New Jersey is not the persistent vegetative state, that's the garden state. Oh, we got to get onto this. Let's look at some definitions of what poor prognosis would be. I don't want you to become the attorney that understands it in the medical term, but you, even as the minister working with these family members, and you start hearing these kind of terms that doctors and nurses are using, I want you to understand that a little better. Terminal condition is a condition caused by injury, disease, or illness for which there is no reasonable medical probability, catch that word, of recovery. They're not definitely sure you're going to die or die soon, but there's something critical. There is an illness that without treatment you might die. The next term is end stage, and this term says a condition that is caused by injury, disease, or illness has resulted in severe and permanent deterioration indicated by incapacity or complete physical dependency, for which to a reasonable degree of medical certainty, treatment of the irreversible condition would be medically ineffective. You hear how this gets worse than terminal. The word terminal sounds bad, and it is, but it is not as bad as end stage. So as I define these, they'll become degree by degree worse. Persistent vegetative state, a permanent and irreversible condition of unconsciousness, which there is absence of voluntary action or cognitive behavior of any kind, and inability to communicate or interact purposely.